Alexander Kotlyar, and we're going to go into fertility preservation options during anal cancer treatment, with special thanks to the Anal Cancer Foundation and to the Farrah Fawcett Foundation. So neither of us have any conflicts to disclose. And as far as our agenda, we're going to do an overview of anal cancer treatment, an overview on the male and female reproductive system, and just how that treatment can affect those systems and what can be done for fertility preservation for males and females. And then we'll have 20 minutes or so for questions. So as far as background for anal cancer treatment for lower stage anal cancer, stage 1 to 3, could involve chemotherapy with 5-FU or 5-fluorouracil, and additional agents like mitomycin and capecitabine. Say that five times fast. In addition to radiation therapy, which is mentioned here, the general dosages range from anywhere from 30 to 45 grays, not given all in one instance, of course, because that would be way too dangerous, but fractionated, meaning given over many instances, many cycles, to give the tissue a chance for recovery. For more advanced stage anal cancer, other chemotherapies are used that could be a bit more. We use the term gonadotoxic. Testicles and ovaries, they're gonads. And these chemotherapies like carboplatin, paclitaxel can affect eggs and sperm much more aggressively. And radiation therapy is also more aggressive. So this is a general overview of the female reproductive system. You can see the uterus in the middle, the ovaries, and they're flanked by the bladder and by the descending colon and rectum. For anal cancer, where it would happen, any excision could affect neighboring structures next to the anus and rectum. But in addition, the chemotherapy would have systemic effects on both the uterus and especially the ovaries. And radiation therapy can have effects throughout this whole area. So we're going to go into what are options for fertility preservation in the setting of these treatments. So the impact of this of anal cancer treatment for women, it could include premature menopause due to loss of eggs. There could be radiation fibrosis just due to the reaction of the tissue to those repeated radiation exposures. For males, you could have depletion of sperm, infertility, and low testosterone because you're also killing off the hormone-producing cells. Now we're going to do a quick overview on the effects of chemotherapy and radiation. So clearly as evidenced by those very well-known symbols. So as an intro, we're just going to review oogenesis, which is the production of eggs. So eggs start off as primordial follicles. During menstrual cycle, some of them are activated to grow. They form primary follicles. Then they form a little pocket of fluid called an antrum. They're called antral follicles. They grow. Woman ovulates, and then this fluffy structure called a corpus luteum, the white body, is formed. Chemotherapy and radiation predominantly affect these primordial follicles, these building block eggs. For spermatogenesis, a similar progression of cell types, going from your stem cells, your spermatogonium, going to more advanced cells that are going to become sperm, and you have segregation of the chromosomes. That's what you need to form gametes, or these initial cells to go into reproduction. So going to the effects of chemotherapy on gonads and on eggs and sperm, it's a spectrum of effects. you have depletion of those stem cells, those oogonium, those spermatogonium, and you also have fibrosis, especially from radiation, that can form around those stem cells, which could also have a negative effect on those stem cells themselves. How frequently, pardon me, those negative effects happen for eggs and sperm, it's tough to get an exact number for anal cancer and for many cancers actually, because it depends upon age, cumulative dose of chemotherapy. But in general, the more advanced age, higher the dose, the greater the damage. This is a slide looking or depicting the general classes of chemotherapies based upon how negative of an effect they have on eggs, and also show it for sperm. So the worst offenders are agents like cyclophosphamide, which aren't used for anal cancer, but just for general information, they're the worst offenders. Thankfully, this isn't the case for anal cancer patients. But but for more advanced cases of anal cancer, platinum agents like cisplatin and carboplatin are used. For less advanced stages of anal cancer, you use 5-fluorouracil and also capecitabine, which is related to 5-fluorouracil, which are more mild as far as negative effects on eggs. And you have a very similar distribution of chemotherapies for sperm effects too. So you also see this moderate effect for cisplatin, carboplatin, and less of an effect for capecitabine and 5-fluorouracil. Now going to radiation. And if any of you are wondering where this picture comes from, it actually comes from a bubble chamber, which was an old school method to visualize radiation. It's very cool. Now, this chart this this chart is showing the mean and effective doses needed to achieve sterility in a woman. You can see we have age on the left side, and as age increases, the average sterilizing dose decreases. So just like with chemotherapy, the older the patient, the more serious an effect radiation has. One confusing point that I think many people will find when they hear about radiation, you're going to hear about Grays, Sieverts, REMS, Röntgens. For simplicity's sake, I'm just using Grays, and what Gray refers to is basically the amount of energy put into a piece of tissue per kilogram of tissue. And Sieverts, that's basically that's very similar to Gray, but it's normalized to biological effectiveness. Some grams of tissue are more resistant to radiation, some are less resistant. For spermatogenesis, in contrast to eggs, sperm are much more sensitive to radiation. For example, you start to have you start to have depletion of sperm at around 1.8 gray, and you can have complete loss of sperm at 8 gray. Whereas for eggs, you need a substantially higher dose. And even after radiation therapy, full recovery of sperm could take as long as 10 years. Now, at this point, we're going to go into fertility preservation methods, and I'll be focusing on the female portion. Dr. Khurgin will focus more on fertility preservation for men. So the options are medications called GnRH analogs. And the second option is the most common option for fertility preservation is egg freezing, oocyte cryopreservation. The third option, as of the past several years, has no longer been deemed experimental and is being more commonly done, which is ovarian tissue cryopreservation. And these next two options, I put asterisks because they're not commonly done and and they require they require some more involved techniques, which I'll go into. So for gene-range analogs, the most common agent used is something called leuprorelin or leuprolide, or the generic name Lupron. So what it basically does is it shuts down the hormonal system that activates egg growth or supports egg development, basically shutting the eggs down. By taking these medications, which come in the form of injections given either monthly or higher doses can be given every 3 months. It reduces blood flow to the ovaries, and by reducing blood flow, it can help limit the amount of exposure of chemotherapy to the ovaries. Then, in addition, they they could prevent, or it's thought that they prevent rapid division of the egg stem cells, and by preventing division, that can also limit the effect of chemotherapy on the DNA of those eggs, further further minimizing any risk during chemotherapy. What do the studies show with these medications? That it's unclear if they save eggs, and this was assessed via pregnancy rates. So in some studies, pregnancy rates were maintained in patients that had cancer and that got these injections, but others didn't show any improvement. What's definite is that they do save that hormone producing ability of the ovary, and they help, at least for a certain period, maintain estrogen production, which is important for both heart health and for bone health for patients and general quality of life. Now, for egg freezing, that's typically done for post-pubertal patients who have a chance to delay chemotherapy and radiation therapy. What many people don't know is that it actually does not take that long to do. So once a patient is diagnosed, and once they're seen by a reproductive endocrinologist, such as myself, they can proceed to starting the stimulation to encourage egg development and to start egg freezing within a few days of being seen. There's a misconception that we need to wait for a woman's menses. Not true. We can do what's called a random start, meaning wherever they are is where we start stimulation, and it has no effect on number of eggs or future pregnancies. One thing to keep in mind, and this is important for establishing expectations, is that the number of eggs that we can freeze depends upon a patient's age and ovarian reserve. And that's very well depicted in this slide. So this slide comes from a paper looking at over 500 egg freezing cycles. On the left side, on the y-axis, on the vertical axis, we have the probability of having at least one live birth. On the horizontal axis, we have the number of mature eggs that we can get from a cycle. And each of these curves corresponds to a certain age. So these first two curves correspond to women that are 35 and younger. And so in general, for a 35-year-old, if we're able to freeze 15 eggs, then they could have anywhere from an 80 to an 85% chance of at least one live birth in the future, which is pretty good. But if you go further for women in their 40s, then a much larger number of eggs must be frozen to achieve anywhere near a comparable chance of having at least one live birth. Um, if and if a patient already knows like who they're going to conceive with, then in addition to or instead of freezing eggs, they can also freeze embryos, which Embryos tend to survive freezing a little bit better than eggs. This slide, while very busy, is actually quite simple if you just focus everything on the left side of where it says oocyte retrieval. So basically, once we make the decision to proceed with egg freezing or embryo freezing, we do baseline blood work and ultrasound. We do stimulation with hormones, the same hormones that are in all of our bodies, but just at higher doses, because we need those higher doses to get as many eggs in one cycle. The stimulation goes on for roughly 10 to 12 days, so not very long. Then when when those eggs look ready, and we can tell that based upon blood testing looking at hormone production and ultrasounds looking at the size of follicles. Follicles are cysts where the eggs are. Once those once those follicles are large enough, then we get the patient ready for an egg retrieval. That's a very quick procedure, takes 10-15 minutes. We take a very thin needle, poke into the ovaries, extract the eggs, and then we see which eggs are mature and we freeze those. After that, the patient's finished. Recovery is very quick. Most patients go on to their daily lives the very next day. And aside from perhaps a little bit of bloating, which goes on for a couple of days, it's an extremely well tolerated procedure. For ovarian tissue cryopreservation, that's done for either a prepubertal patient or someone who cannot wait the 10 to 12 days to do egg stimulation. And that does involve surgery where laparoscopy is done, a piece of ovarian tissue is removed or a whole ovary is removed. That's flash frozen in liquid nitrogen. And then after cancer treatment, that tissue is reimplanted, and then the same stimulation protocol is done to encourage egg growth and to harvest eggs. And now I'll turn it over to my colleague, Dr. Khurgin.
Thank you, Dr. Kotlyar. Thank you very much. I learned a lot because I do mostly male, so I didn't know that things were different. No, I'm just kidding. Um, Thank you very much. I'm going to share my screen, and please let me know if you don't see something. Hopefully everybody can see my screen. And we'll take it from this slide where we're going to just talk a little bit about the male reproductive system. I was kidding before. I knew it was a little bit different. Um, the slide in front of you shows all the major structures that we're not going to go over per se. There's no quiz at the end, but the important thing I wanted to point out is, as you can see, the anus, and we're talking about anal cancer, and a lot of the male reproductive organs, the accessory sex organs, as we call them, are really nearby. So there is a direct effect from treating something here to something that's here. As you can see, the proximity is there. And in case men out there, especially men over 50 years old, who've been told they need a prostate exam and they're wondering why, if the doctor's finger goes into the rectum, you can see that the prostate is nearby. So you can feel a part of it. We're not just trying to torture you. It's actually very close. All right. So let's talk about what some of the major cancer organizations out there think about fertility preservation. The NCCN guidelines recommend discussing the risks of infertility due to cancer and its treatment with all patients at the time of diagnosis and prior to initiating treatment. So preserving rather than dealing with it afterwards is what we're going to be focusing on. Here's another NCCN guideline. This one is addressing young adult and adolescent patients. And it's a busy slide, but as you can see there, they recommend highly to discuss the risks of infertility due to cancer and its therapy, and specifically for males, discuss the possibility of sperm banking and suggest a local sperm bank or available online. sperm banking kits. And actually, this is a few years old, this guideline. And since then, there's been quite a few online options where they send you a kit. All you have to do is provide the sample, and then you send everything prepackaged back. And it's fairly straightforward, fairly easy. So we're living in an age of Uber Eats and all this. So this is close to that. A question we get is, what is the baseline fertility in patients who are diagnosed with cancer? And the truth is that most, not all, but most will have normal baseline semen parameters. In other words, the fertility is not affected by the cancer. One study I wanted to highlight from about a decade ago looked at 400 American men trying to answer that question. How many of those have normal baseline semen parameters and how many have abnormalities? Oligospermia just means low sperm count, and azoospermia means zero sperm. And they found that men without a cancer diagnosis, about 10% have an abnormality like that, whereas cancer patients was a little bit higher at 15%. But as you can see, that means about 85% will have normal baseline parameters. So we have men mostly with normal sperm counts to start. As Dr. Kotlyar mentioned, treatment for cancer, anal cancer, and other cancers is often multimodal, which means we use several things: chemotherapy, radiotherapy. They're sort of mainstays in anal cancer treatment. Surgery is also an option in certain scenarios, but each one of them can contribute to infertility. So just to expand a little bit about why this happens, and specifically why chemotherapy in men, the sperm producers, why it affects things. Sperm are produced all the time in men. They're produced at a rate of about 1,000 to 2,000 sperm per second, believe it or not. So 1,000, 2,000 sperm, 3,000 sperm are made all the time. So what that means is these are very fast dividing cells, and chemotherapy affects the way cells are able to divide. So it affects preferentially those cells in the body, like sperm cells, which divide quickly and often. That's why often with chemotherapy, you have an effect on sperm not being able to be made. So some of the chemotherapy that Dr. Kotlyar mentioned, the way they work, again, there's no quiz at the end, but 5-FU is a chemotherapy agent that basically disrupts RNA and DNA synthesis, and it does it both in the cancer cells, which is what we want, but also in the non-malignant or non-cancerous cells. Specifically in sperm, it affects the seminiferous epithelial cells and the Sertoli cells. So those are both the mother hen cells, the Sertoli cells that help support sperm production, but also the outside lining of where the sperm cells live. Either way, what that leads to is a reduced sperm count. And the picture here is DNA and RNA, and you can see that some other chemotherapy agents, in this case, mitomycin C, that's also a pretty common agent that we use in anal cancer. Mitomycin C is what's called an alkylating agent, which means it kind of disrupts the structure of the DNA and makes it impossible for it to divide appropriately. DNA synthesis is inhibited by this cross-linking that is demonstrated here. And again, won't bore you with the details, but the point is that it can lead to a reduced sperm count. Carboplatin, which is a platinum-based agent, is also a DNA disruptor, again, by cross-linking. This is just a different visual of DNA without the cross-linking. Then cisplatin, which is very similar to carboplatin, causing these additions and then prevents the synthesis and the division of the DNA and replication. We have some decent data, mostly from another condition, from testicular cancer, of men who receive platinum-based chemotherapy. It's very difficult, as Dr. Kotlyar mentioned, to know exactly what effect chemotherapy or radiation will have on fertility because the baseline fertility might be different, ages are different, the type of cancer and how aggressive or how advanced it is, and when you measure it and whether the doses of things are different. So it's a very disparate group of patients. So it's hard for us to predict very well what is going to be the effect of this treatment specifically on you. That being said, with platinum-based chemotherapy, we see that about 50% of men will have a recovery of their sperm production at the 2-year mark. And if you wait 5 years out, about 80% will have sperm production recovered. So these numbers are not perfect, but they also tell us that there is sperm production and life after chemotherapy. Specifically in platinum-based agents, tends to do better in terms of recovery than cisplatin, which is an older agent. A couple words on radiotherapy. Again, Dr. Kotlyar mentioned this. Because sperm are very sensitive to radiotherapy, even lower doses can potentially affect things. How much it affects, it depends on the dose. I used gray in this rather than sieverts, but the point is the lower the dose, the possibility is that it won't affect things at all, or if it affects it by giving oligospermia or a low sperm count, that recovers. Around the 1.8, 2, or 4 gray mark, that's when you start to see azospermia. Azospermia is 0 sperm. In the lower range of the radiation dosing, we expect azospermia to be temporary. But as the dose increases, it's much more likely to be permanent. Interestingly, around the 4 gray mark, you usually have azospermia that is permanent. So one of the things that is done often in radiotherapy is we have the gonads, specifically in men, the testicles, covered and sort of protected as best as we can, usually with lead, to avoid the radiotherapy effects on the area that's producing the sperm. Leydig cells, these are cells that produce testosterone. That's the main so-called male hormone. They're also being produced in the testicles by these Leydig cells. They are more hardy, so they can take more of a beating from radiotherapy, and they can continue to do their function to a point. So, for example, at the 2 gray mark where sperm production is affected in most men, the 2 gray mark also means that Leydig cells are usually not affected and your T or testosterone levels are the same. However, when we start getting into a higher dose range, something similar to what Dr. Kotlyar was mentioning about oogenesis being affected, around 14 gray, about 1 out of 2 or so men will have a loss in their testosterone making ability, and about 40% of men overall will require TRT or testosterone replacement therapy because their body is no longer making it. Surgery, just a few words about that. Surgery is one of the multimodal therapies that we do for anal cancer and many other cancers. Once you start operating in the pelvic or retroperitoneal area, which is sort of, if you feel your pubic bone in that region down there, you can affect not necessarily the testicles, but the nerves that go into the testicles and the other sexual organs in the body. And while your sperm production might be fine, the way for them to come out, which requires usually erections, orgasm, and ejaculation, that can be affected. So surgery sometimes will not necessarily affect the production of sperm, but it will affect the ability of a man to have that come out to the outside world. So it depends on what is damaged. You can actually have erectile dysfunction, ED, or you can have ejaculatory issues. So we know that we can have these effects on fertility from necessary treatments for anal cancer and many other cancers. So the question becomes, how utilized is fertility preservation? And really, this is in the field of oncologists, who are the primary providers for people diagnosed with cancer. Um, One study from about, I think it was about 12, 13 years ago, found that less than half, less than 50% of oncologists routinely adhered to the ASCO guidelines. ASCO is a big cancer organization in America, and the ASCO guidelines recommend, quote, address fertility preservation as early as possible and importantly, before treatment starts. Now, in the same study, the oncologist overwhelmingly agreed, over 90% agreed, that sperm banking should definitely be offered, right? So there seems to be a disconnect. Less than half are doing what they think is appropriate. More than 90% think that sperm banking, which is the mainstay of male fertility preservation, is not being done. So what are the barriers? This study showed time constraints was one perceived barrier. In other words, we're talking about cancer. We're talking about saving your life. We don't have time to talk about those other things. And this is probably where a patient could be a self-advocate and bring it up on their own and help get that conversation started. Cost concerns. Another is the assumption that this is a very expensive thing. This is something that, if you're past a certain age, you maybe don't care about, and that's why it's not offered. Well, in reality, sperm banking is usually not free and usually not covered by insurance, but overall, it's not a very expensive treatment. Lack of convenient facilities. In other words, medical oncologists might not know where the closest sperm bank is. Some of them will have, inconvenient times for appointments, things like that. And as we mentioned, now there's an increase in the online options, so hopefully we can circumvent that. And the same study also found that sperm banking was offered less in certain groups of men, specifically men who have sex with men, patients with an HIV diagnosis, and those patients whose cancer tend to have a poor prognosis. Again, showing some bias that maybe we can address and empowering patients to say, hey, I'm interested in this thing, and that gets the conversation going. So what is the solution? Some of the things I mentioned, and of course, awareness about the subject. Obviously, getting a diagnosis is overwhelming, and oncological treatment is really what you should be concentrating on. It doesn't mean that nothing else exists. And we thank the Anal Cancer Foundation, ACF. Thank you for helping with this awareness to males, females, and whoever the loved ones are. And we say things. And one of the things that I wanted to say is that in a study showing men who cryopreserved their sperm, about 2/3 after a survey was given said they were extremely satisfied that they did so. We're not talking about 30 seconds after they gave the sperm, because a lot of them are satisfied at that point, but we're talking about months and months and years later. So let's talk about sperm banking. A semen sample is usually all that is needed for male fertility preservation. Most of the time, there's sufficient sperm acquired by ejaculation. What does that actually entail for the person who is interested in this? You basically have a date with a little container. How you get it filled? Some people want to say thank you, Hugh Hefner, or other things. This predates the internet, obviously. But the point is, you're able to fill it with semen. It's not a medically risky procedure, and it is relatively inexpensive. So that is the first step. Things to keep in mind. Ideally, we want this to be done before any treatments, because there is the potential that treatment not only decreases your sperm count, but also can affect the quality of certain sperm, which we don't necessarily want to use in the future. There are men out there that have different religious or cultural considerations. There are specialized collection condom kits, which can assist with that. And a lot of men may have some issues with masturbation, and a lot of times consulting with their clergy can be appropriate. Another important thing about the semen sample, even if the results are not, perfect, they're not 100% normal in every which way, that does not mean it cannot be preserved. In fact, we highly recommend that even oligospermic or poor sperm count samples will be preserved for future use. There is a subset of men that are not able to provide a semen sample because they have ejaculatory issues. There are solutions for that too. One of the more common ones is called penile vibratory stimulation, which helps with ejaculation, and electroejaculation, which is a little bit more invasive and done under general anesthesia, will also induce sort of the natural pathway of sperm to come out to the outside world. If you require a general anesthesia procedure, this can sometimes be coordinated with other procedures. People might need a chemo port placed under a general anesthesia or another type of cancer-related procedure. So this can be added at the same time so as not to give any extra anesthesia. Now, there are men that either have zero sperm or they are unable, despite our best efforts, to provide a sample. There are tissue retrieval options at that time. In other words, you go to the source, the testicle itself or the epididymis, which I'll go over in a second. You go directly to the source, to the gonads, in women it's ovaries, and men it's testes, and you try to harvest some sperm directly from that. How you do it depends on several things, but it can be broken down into two main categories. It could be done under local anesthetic, kind of like when you go to the dentist and they give you hopefully some good local anesthetic like lidocaine or marcaine, and then they're able to pull your tooth. Or it can be done under general anesthesia, and like I said, can be coordinated with other procedures. The source of the sperm can either be the epididymis, and I have a little picture here. Epididymis is a little structure that sits on top of your testicles, and that's where sperm go to mature. So theoretically, this houses a lot of moving sperm, where the sperm learn how to become, squiggly and moving at the epididymis. Or you can go directly to the testis, which is where the seminiferous tubules are, sort of the factory that makes the sperm. And if you do any Googling about sperm preservation in men, you'll probably run across these acronyms: PESA, TESA, MESA, TESI. It's very confusing. It's probably done on purpose so I can continue to have a job to understand what those acronyms mean. But the point is, it's either done locally with just without general anesthesia, and you're either going directly to the epididymis or directly into the testis. The end result is what we hope, to be able to retrieve sperm, and those can be cryopreserved or frozen for future use. Again, can coordinate with other procedures. And a common question I get: is male fertility preservation safe? There's a lot of data about this. The bottom line is it is considered safe. There is a concern about whether radiotherapy, whether chemotherapy can affect the DNA within the sperm cells, and theoretically, will this be passed on to future children? So the general recommendation is to wait at least one full life cycle of sperm production. As I mentioned before, sperm are constantly being made, 1,000, 2,000 sperm per second. That process takes about nearly 3 months. So we think that once you have a treatment, it's done. About 3 months later, you'll be able to have completely new sperm that are unaffected by the treatments that you had. Excuse me. So as a general recommendation, instead of saying 3, most experts agree that at least 6 months is worth waiting, and some people say over that time to a year or two afterwards before trying to conceive naturally. And the same, excuse me, organization that I mentioned before, ASCO, has some answer to this question of the safety of fertility preservation in men. And just to quote them, aside from hereditary genetic syndromes and in utero, in other words, pregnant situations, and in utero exposure to some chemotherapy treatments, the highlighted part is important. There is no evidence that a history of cancer, cancer therapy, or fertility interventions increase the risk of cancer or congenital abnormalities in the progeny. So, in other words, safe. And not only is it safe, it tends to work. The sperm don't have necessarily a limit of how long they can be frozen for. The oldest report I'm aware of is 28 years. So there was somebody who preserved their sperm as a teenager. It was frozen for 28 years. And nearly 30 years later, they had a child from this cryopreserved sample. Pretty miraculous. And that's why, as I said before, please preserve anything that is retrieved. It does not have to be a perfect sample. Theoretically, any sperm is worth saving, and you can get your goal. And, there is hope. There's additional resources that you guys are welcome to look into. Obviously, the ACF is an excellent resource as well. And I think we have some time for questions. I'm going to stop sharing my screen here. All right.
That's great. Alex, Jacob, thank you for a absolutely fascinating session. And yeah, absolutely. Really, Jacob, to your point, that message of hope and optimism that things are possible. I think that's really important to share. So we have had some questions come through, and I just seen someone in the chat saying, Helen, please do put in the Q&A if you have some questions. I saw there's a question from Feline. Do ovaries still produce significant amounts of hormones in post-menopausal women? Alex, I assume that we'd be thrown to you for that one, if I could ask you to come in there.
Sure. So, Feline, great question. Yeah, so yes and no. No, in the sense that the levels of estrogen produced in postmenopausal women are far lower than they are in premenopausal women. However, however, they're still producing hormones, but they're still producing percentage-wise more male hormones like testosterone. And testosterone is actually a precursor for estrogen. But in short, the amount of hormones is in general lower than the premenopausal state.
Okay. Okay, I'm just gonna put one of the questions that I had for both of you, just whilst we collate that from Helene. Are these treatments generally covered by insurance that you've been speaking to today?
So for egg freezing, in the setting of cancer, whether it be anal cancer or any other form of cancer, many insurances do offer the option of egg freezing. In the US, it depends upon the state. So New York City, it's quite generous. It also depends upon the insurance carrier. One common question is cost for egg freezing, for example, since that's the most common modality used by patients. Um, it If there's absolutely no coverage, then based upon the region, it can be anywhere from like 7,000 to as much as 13,000. But there are many organizations like Livestrong that'll give you subsidized or even free medications, so that substantially decreases the cost by thousands, actually. And oftentimes, especially in mandate states like New York, there will be substantial insurance coverage.
Yeah, just to echo that, I think, David, you're in Britain where there's one healthcare system, so there's an answer, yes or no, I'm guessing. Uh, the healthcare system is a little bit more erratic here in the States. And like Dr. Kotlyar said, it is based on where you are state-wise, what insurance carrier you have, what plan within the insurance. Um, a lot of times in the male arena, if you have a cancer diagnosis and you're doing something related to that, there are kind of clauses to cover fertility preservation. It's not universally covered. The uh, the advantage is if you don't require anything special in terms of procedure wise, and you just require a semen analysis with cryopreservation, you're looking at something that costs a few $100s, most likely. And then cryopreservation of uh, either um, eggs or embryos or sperm does require a maintenance fee, also usually on the order of a few $100s every year.
Thank you. And I think actually, if we go to Helene and Christopher's comments, so to Helene's first, she's mentioning around some men after radiation treatment having painful ejaculation and ED. Can you speak to that? And I think that sort of goes in to that sort of blends with the question here. After radiotherapy, I have tight skin and anus and scarring, and also can't ejaculate. Is there anything I can do for this that perhaps you might be able to speak to?
I'm guessing that's my arena.
Yeah.
So most likely, erectile dysfunction can be a side effect of some chemotherapy agents, and specifically in anal cancer, because radiotherapy, as we showed in that anatomy slide, the proximity is right there, and the nerves that connect your brain to your spine to your penis, that last connection point is really right there. Then very frequently we actually see erectile dysfunction, new erectile dysfunction after radiotherapy. Uh, the good news about ED is that it is very common and also very treatable, and there's a gamut of things that you can do, from medications to injections to surgery, that is usually recoverable. The other question about dry ejaculation or painful ejaculation, that probably has to do with scarring related to radiation, mostly in the prostate and seminal vesicles. Those are the organs that produce the majority of the volume of things that come out when you ejaculate. So one of the important things about fertility preservation is if you don't ejaculate, you cannot be, fertile naturally afterwards. So again, it goes to the point of fertility preservation being so important. But a lot of times, orgasm, which is this pleasurable sensation that usually is accompanied by ejaculation, usually that is preserved, whereas ejaculation is not preserved. In other words, you can have an orgasm without ejaculate. So at least from a sexual satisfaction perspective, a lot of times you're okay.
Thank you. I've got another question here. Can anal cancer treatment impair a woman's ability to achieve orgasm? Is this typically temporary or permanent?
So great question for that. Oh, great question in that regard. It depends upon the amount of radiation a woman has received, because radiation itself can lead to fibrosis, scarring around the cervix, around the vulva, and depends upon the amount of radiation therapy a woman receives. If it's on the milder side, then there's less scarring, and the amount of scarring can affect nerve sensation, but can also relate to pain during intercourse. Um, and especially if it's mild, with dilator therapy, perhaps with estrogen creams or gels, that could recover at least some of the vaginal tissue, and then that pain or scarring that would make it harder to achieve orgasm could be addressed, but especially if higher doses are used and if there's recurrent disease, then most likely it would be permanent. Decreased sensation, increased pain, and some anorgasmia.
And I guess to sort of follow up on that, do you address fertility impact of immunotherapy or targeted therapy? And if so, what are the nature of those conversations that you have with people?
Yes, so in general, it's a brighter outlook with immunotherapy because a lot of the receptors and molecules that are being targeted aren't the same ones on eggs. And so say if just these monoclonal antibodies for immunotherapy is given, I'm less concerned about depletion of early eggs. For targeted therapy, like one common medications used for targeted therapy are PARP inhibitors. There's we know less about them, but there's increasing data, at least in the breast cancer population, that they could have a negative effect on eggs. In general, in general, whether it's immunotherapy, whether it's targeted therapy with PARP inhibitors or traditional chemotherapy and radiation, I always tell patients and also oncologists that you can never make an assumption. You should always act as if there's that risk for loss of eggs and sperm.
Yeah, I think that's right on. I think that the problem with these agents is they tend to be less toxic compared to chemotherapy overall. And there's a lot of really positive data on how well they can help with different cancers. But the medications have been around a shorter amount of time. We don't have as much information that has accumulated over decades as chemotherapy agents. So a lot of times we're a little bit unable to give a fully informed answer. The majority of the answers come from animal data. In other words, mice that have been exposed to sort of mega doses of this either targeted or immunotherapy. And most of what I've seen sperm wise, it does not seem to be a major negative effect. But again, as Dr. Kotlyar said, we cannot bank on that. We can't be 100% sure. So we usually do recommend fertility preservation regardless.
I had a question for both of you in terms of sort of timings to sort of find appointments. So if someone were diagnosed and then they were wanting to think about fertility preservation, and my guess, Jacob, would be perhaps as a male, it might be slightly quicker to explore some of those fertility preservation options as a male, as in terms of sperm banking, for example. But that's just an assumption that I'd have. Could you both of you perhaps sort of speak to sort of timeframes that would be looking at to perhaps sort of explore some of these options?
So, yeah, you're right about men, could be as little as 30 seconds. Depends on the situation. um, Average is about 5 minutes worldwide, just so you know. But yes, the logistics of getting an appointment where you want to is going to be probably the most time-consuming part of it. Luckily, men are not they don't require hormonal manipulation per se. So really, you're not time constrained. It's just getting the logistics of getting you a date with that container.
And Alex, could you perhaps speak to for some of those female for females some of those fertility preservation options and timeframes?
Yes, so for egg freezing, embryo freezing, that all can be done. Um, and this actually goes to Carol's recent question. So egg freezing, embryo freezing, egg freezing can be done within about 10 to 12 days. After being seen by us, and those appointments can actually be set up very, very quickly. Oftentimes a patient's diagnosed, they speak with their oncologist contacts the clinic, gives us the patient's information. Within 1 to 3 days the patient's seen. Like we always make time for cancer patients, given the urgency. As far as embryo freezing, that takes about an extra 5 days because we want to fertilize the eggs, make ideally blastocysts or day 5, 6 embryos. And going to a question, it's if you can freeze embryos, if there's a sperm source partner, however you wish to interpret it, then embryos generally survive freezing better than eggs because they're a whole mass of cells that are well organized, and eggs are just a little bit less resilient. And also because you know how many eggs have been fertilized, you know how many embryos, then you have a better idea of what's the fertility potential in the future. With eggs, say if you get 20 eggs, well, 18 of them could fertilize, maybe 12 will fertilize. But there's always some attrition at that level. Um, and then I also just wanted to mention one other thing or a few things that I didn't have that, for the sake of brevity, I couldn't go into too much detail. But say if women didn't have 2 weeks, or for various reasons didn't want to do egg freezing or embryo freezing, especially to protect against radiation, they can do what's called ovarian transposition, which is a relatively simple procedure where the ovaries basically are disconnected from the uterus, um, and then repositioned about 4 centimeters, just under 2 inches away from the radiation field, and that's guided by the radiation oncologist. Also, a newer and much, much rarer surgery that's done, that could be done relatively quickly after diagnosis, is uterine transposition, where the uterus is basically disconnected from the pelvis and placed above the radiation field. Um, it's still, to my knowledge, only done under research protocols, and only very, very few centers do it. Um, but um, but for most patients, we find don't need that level of intervention. Thank you for letting me give a long-winded answer.
No, that's absolutely is the sort of depth that I know that people be looking for, Alex. That's super helpful. I'm conscious of time, so we're just going to have one more. And Jacob, this is for yourself in relation to chat. If someone's having difficulty maintaining erections and ejaculating, are there operations that are available to regain that level of sexual function?
The short answer is yes for erections, not so much for ejaculation. While erectile problems are common not just in cancer patients, not just before or after treatment, but anybody for many other reasons, diabetes, hypertension, just getting older. So it's a very common issue, and about 99% of the time there's a solution that will work. How significant that solution is, whether it's just pills like Viagra or Cialis, which we've all heard of, to a surgery, which is penile implant surgery. That depends on what you've tried. Obviously, a good conversation between the patient and the physician. And but they're by and large, everybody has some solution for that. Ejaculation is something that's more difficult to treat, and also something that we're less keen on treating. The reason being, the organs that produce the ejaculate are very deep in the pelvis, and sort of fixing them is actually a major surgery that doesn't guarantee good results and can have a lot of side effects. Most of the time, ejaculation is important for fertility preservation. And because of everything that we've talked about thus far, we know that we can get someone pregnant without ejaculation. And that would be the preferred option. The other thing is that a lot of times we need to look into is when you've had these treatments, your hormone production of the testes, specifically testosterone levels, can be affected. And those have a whole host of issues, but sexual dysfunction of some sort is very common with low testosterone. So that's something that, can be checked for, can be treated as well.
Thanks, Jacob. Well, ladies and gentlemen, I'm afraid we've come to the end of our time, which Alex and Jacob have generously given us. Thank you, Dr. Kotlyar and Dr. Khurgin, for a fascinating session today, and as worth repeating, for sharing this message of hope that fertility preservation is possible for those undergoing anal cancer treatment. It's worth saying we will be publishing this session on our YouTube channel on the website after the event. So if you are wanting to go back, revisit some of the comments and questions, you haven't managed to take all the notes down. I know I've been scribbling away, but I'll be revisiting this. It will be available, so you can revisit it, share it with caregivers, loved ones, or clinicians. So thank you for joining us. We will be having our next webinar discussing ctDNA detection as a biomarker of outcomes in anal cancer care in December. So please do keep an eye on your inboxes for that one and the follow-up to this. So thank you, everyone. Have a lovely day wherever you are, and take care.